Good afternoon, everybody. Thank you very much for being here. We are super pleased to have you at the 16th annual Hewitt Lecture. I'm Jim Sturgis, Executive Director of Pioneer Institute, and it is great to be back at the Joseph Martin Center. It feels like home here. We've done this event here 11 out of the last 16 years, and it's been a terrific venue for us. We appreciate the partnership from the medical school. Few of you are new here. I'm just going to give you a quick thumbnail on Pioneer. If you don't know much about Pioneer, three basic things to know. We love Massachusetts. It's our headquarters here. We do a lot of work in this state, but we also do, and this is the second thing, work in a lot of states at this point. Our emphasis is on innovations. We've given up a lot of our work that we used to do on trying to fix old legacy systems. Part of what you're here tonight is a progression to an interest in the life sciences. We used to do a lot of work on healthcare delivery systems. We are less interested in that. We believe that we can have an impact on this issue and others by focusing on places where we can really have a competitive advantage vis-a-vis other institutes. The third thing is when we do work in other states, it's working with local groups, bringing thought leadership where we can, and media. That's been most of what we've done, but the thing that distinguishes our work in Massachusetts is that we have started a law firm under the leadership of Frank Bailey, former federal judge, who's doing an absolutely terrific job, just won a significant case on home equity this past week. We're pleased with that. And we will be filing probably May 1st, our first big education case on school choice in Massachusetts. We're really pleased with the progress there as well. I think you all know we care most about education. Education is 50% of what we do. Charter schools, vocational technical schools, high quality liberal arts. We do that here and around the country. The second area that we work in is economic opportunity. And frankly, we have a lot of work here at home. Most of our work is here in Massachusetts. The tax amendment that was passed is a big deal for us. We can see in the data all the time now that there's I think the Globe said just past week, people are leaving Massachusetts in droves. There's recognition that this is happening. The Law Center is also focused on these issues, and you will learn in the coming months that we are starting another organization with other business partnership groups to fight back on this. And this will be much more of be separate from Pioneer. It will be a much more of a political organization that drives home that message. We're here for healthcare, though, and that's the third leg of our stool. And I'm really pleased that we are able to have with us Congressman Jake Auchincloss with us, as well as with Robert Popovian. We'll interview him just a little bit. I want to give you a little bit of a backgrounder on the healthcare lecture. It's in honor of Colby Hewitt. Colby was our longest serving chairman, and he is the great man who brought us the Hewitt family, and we're deeply, deeply grateful for their involvement. John Marston and Josie Marston as well. Super pleased that we are able here to honor him and have a great speaking event. I'd also like to say thank you to our sponsors, because without our sponsors, this event, this location, we would not be able to hold it in. So let me just say that we're very thankful to AbbVie, Bruce and Holly Johnstone, Eli Lilly, and Pharma as our platinum sponsors. Our gold sponsors are Chuck and T. Hewitt, Josie and John Marston, and our silver sponsors are Bristol Myers Squibb and Fred Clifford. If you give them a round of applause, I'd appreciate it. So this lecture over the years has progressed. We have done a lot of work with federal and state leaders in healthcare, folks from the insurance industry, folks from hospitals, life sciences institutions, experts on vaccines, opioids, drug policy, the rise of competitors to hospitals, international approaches to healthcare, so much. But most recently, we have focused, as we have built a great team on the life sciences, on the life sciences. And I just want to recognize Bill Smith, who's the director of the Pioneer Life Science Initiative. Obviously, Robert Popovian, who's a senior fellow with us, and Gary Binoy, who's a researcher as part of that. But this evening, we have an opportunity to hear from Congressman Auchincloss. I'm going to introduce him and Robert Popovian, and then invite Robert to come up and introduce the topic. So Congressman Auchincloss is serving his second term representing Massachusetts 4th. In addition to his work on the committees for transportation and infrastructure, he is on the select committee for strategic competition between the US and China. His areas of focus, in addition to that, include healthcare, why we're here tonight, clean energy, gun violence, and building a strong middle class. He has a remarkable background. He is younger than most people in the audience, not everybody. He's born and raised in Newton. After graduating from Harvard, he joined the Marines. He commanded infantry in Afghanistan and special operations in Panama. When he came home, he worked for a Fortune 100 insurance company and a cybersecurity startup, even while he found time to run for office and serve as a Newton city councilor for 3 terms. He has degrees in economics and finance from Harvard and MIT Sloan. Obviously, he doesn't sleep. Pleased to have you with us. Interviewing Congressman Auchincloss is Dr. Robert Popovian. Dr. Popovian is a senior health policy fellow at Pioneer, as I mentioned just a second ago. He works with Bill Smith and the team. He is the founder of the strategic consulting firm Conquest Advisors. He previously served as the VP for US government relations at Pfizer. He is one of the country's foremost experts on every significant facet of biopharmaceuticals and the healthcare industry. He is a recognized authority on health economics policy, medical affairs, and strategic planning. He was recently appointed as the Chief Science Policy Officer for the Global Healthy Living Foundation. He serves on the board of counselors at the University of Southern California's School of Pharmacy. He's a senior policy fellow at Progressive Policy Institute and on the board of advisors for Equidium Health. He completed his doctorate in pharmacy and Master of Science in Pharmaceutical Economics and Policy at USC with honors. Tonight, Dr. Popovian and Congressman Auchincloss will be discussing the role of pharmacy benefit managers. Before inviting Robert to come to the podium, let me just start with a definition, if I may. A pharmacy benefit manager, or PBM, you'll hear people talk about PBMs, is a third-party middleman between insurers and drug manufacturers who creates formularies, negotiates rebates and discounts, often which flow back to them, processes claims, and reviews drug utilization. I'd like to welcome Dr. Popovian to the podium, but I would invite all of you afterwards to stick around for a drink because he's here on his birthday, which is really gracious of him. You were from there? Yep.
You know, what Jim says is absolutely true. We're going to talk about the pharmacy benefit management companies, but we're going to focus on drug pricing, spending, affordability, access. But before we get started with the congressman, I'm just going to give you some synopsis of where they came from. I'm a pharmacist, a trained pharmacist, and what Jim said there is absolutely true. PBMs are the quintessential middleman, you know, and they were created in the, I would say, the 1980s, 1990s. When I was in training, they were a godsend because they came into the marketplace. They were able to process prescriptions really quickly in the pharmacy, and patients walked in, they knew exactly what they were going to pay out of pocket. And they did a fantastic job. I mean, they organized the entire market, you know, and this is when the insurance companies only supported about 50%. Only 50% of people actually had insurance for pharmaceuticals. Now that we're at 100%, they still do that job, and they do a fantastic job. But over the years, they've evolved. And they've evolved into really developing benefit design, trying to tell you how much you end up paying for medicines and what the price of the medicine will be for your benefit. But beyond that, they've also engaged in contracting tactics with the biopharmaceutical companies, which is not a small amount. We're talking over $200 billion gets funneled back from the biopharmaceutical companies to this middleman. Now, what number of that 200 billion ends up as profit versus goes back to the consumer, we don't know because it's a black box, and this is where the congressman is going to explain some of the work that they're doing in Congress. But beyond that, they've evolved into owning specialty pharmacies. So if you want a brand name drug, they're going to be dispensing it to you. They have offshore companies now that they're doing rebate collaborations together and everything else. So that's what one of the areas that FTC is looking into. But the best way to put it is that they've become this huge oligopoly, and the three companies that have created this oligopoly, which is CVS Health, Express Scripts, and Optum Health. And if you want to learn more about this, there's a great bipartisan report by Senate Finance. Senators Grassley and Wyden did a great job of putting this out, and it really explains what PBMs do. But without further ado, I want to start with some questions for the Congressman. And I want to start with asking you, I mean, when you hear biopharmaceutical innovation, and I know you have a personal attachment to it, what do you think? What is the first thing that comes to mind to you?
Dr. Popovian, I appreciate your time, especially on your birthday, to
Thank
talk
you.
about drug pricing. We got two drug pricing nerds that I know we're going to rock out. And thank you all for joining me as well in this important and timely discussion. You're right. I grew up in a biomedical household. My mom, my dad were researchers, were physicians, and so grew up with a deep respect for science, and particularly for drug discovery. And when I hear the word biopharmaceutical innovation, the term biopharma innovation, a number of things come to mind. One is exciting. Everyone's talking about AI these days, AI this, AI that. People talk about crypto or Web3. People are talking about quantum computing. I think far and away, biology is the most exciting domain of the 21st century. Biology is where the action is going to be. In the 1800s, chemistry became an engineerable discipline, and people could take what they had learned from the science of chemistry and apply it to materials and chemicals, and it changed human standards of living. In the 20th century, the same thing happened to physics. Scientific understanding of physics became rigorous enough that you could then have engineerable physics, changed human standards of living. 21st century is going to be biology. The science is good enough, the programmability of biology is becoming tractable enough that there are people, scientists and engineers, who can program biology, and that is going to change human standards of living for healthcare for sure, but also for agriculture, for manufacturing and materials, for chemicals. It's going to feed, fuel, heal the world. So it's exciting. It's also fragile is the other term that comes to mind. It is, so many things have to be true for a biopharmaceutical industry to be able to thrive. You need a very strong and stable intellectual property regime, because investors are putting tremendous amounts of money behind a piece of paper that says, hey, we have this idea and you own it. And that piece of paper is highly tenuous, and unfortunately we're seeing some cracks in that facade right now. You need, of course, robust funding for the academic medical centers that create that clinic to laboratory, bench to bedside learning that allows new ideas to come. You need a university system that can train these scientists and engineers. You need an insurance system that has the premiums that creates a market for this. Because otherwise, as you said, even 40, 50 years ago, there wasn't an addressable market for biopharma because there weren't the premiums to pay for those. So it is unusual, almost unique in America that we even have this thing. And that leads me to my final reflection on that term, which is Massachusetts. If the US is lucky to have this industry, boy, oh boy, Massachusetts needs it real bad. People come to Massachusetts not because of the weather, not to learn how to drive. They come here because we cure disease. That's what we do in the Bay State. That's the thing that we are better at than anybody else in the world. And I have the privilege of representing the densest concentration of biomedical talent of any congressional district of the 435. And so I see it. I can throw a rock and hit the CDC director and the NIH principal researchers and biotech entrepreneurs. It requires this density, this network effect of talent that is very hard to replicate, but that can unravel very easily. And we have to be very cautious that we don't allow this to unravel here in the Commonwealth.
I have to say, I mean, Bill and I, we worked together at Pfizer, and we observed the evolution and the growth in the biopharma sector in Massachusetts. It basically went away from California to Massachusetts.
Kendall Square was parking lots in the
That's right.
90s, and then it
That's right.
became
Overnight, it became an evolution. So we're here today to talk about PBMs, and you and I spoke. First time we spoke was on a Saturday, which tells you how much of a nerd we are about drug pricing. And we had a long conversation. We went back and forth, and you challenged me a lot about some of my assumptions and everything else. And that was a good conversation because it made me think how I can explain things better. But what are your, why are you interested in the PBMs, and what do you think the problems are in this pharmacy benefit management world that we are at?
I'm primarily interested in PBMs for two reasons. And the first is, might sound weird, but I love health insurance, actually. So my criticism of PBMs comes actually from a place of love. I worked in the insurance industry for a couple of years, in the P&C industry, not in health. But health insurance is a relatively recent phenomenon, really the last century that we've had health insurance. And it's a wonderful financial services innovation because it creates peace of mind for people that's very difficult to qualify. But it also creates a market for medical innovation. There was previously no incentive for anybody to try to produce these wondrous new services and goods, but health insurance premiums have created a wonderful addressable market for innovators. And so I want it to work better. And the pharmacy benefit managers are perverting the purpose of health insurance, which is fundamentally not just a financial contract, but a social contract. When you pay a premium, you're getting a promise from the insurance company. It says, I'm healthy right now, I'm paying you a premium. And that premium means that if I get sick and a doctor prescribes me an appropriate medication, you'll pick up the tab. That's the point of it. But what the PBMs are doing is they've gotten hooked on the rebates, on the spread between the list prices and the out-of-pocket costs. They've gotten hooked on the power of being in the middle between the manufacturers and the pharmacies. And it started slowly in the 90s, but then it picked up steam in the 2000s. And boy, it was some big money. If you want to look at how much the money it was, look at United Healthcare's quarterly profits, $5, $6, $7 billion. And what that has done is, one, it has perverted the incentives for the biopharma industry. And two, it's leaving patients and pharmacists out to dry. Patients are paying out-of-pocket costs for drugs that their doctor tells them that they need, and that they paid premiums precisely so they wouldn't have to pay out-of-pocket costs. The only economic justification for out-of-pocket costs is moral hazard, is this idea that you're going to overuse something, you're going to act poorly because you've got insurance cover. And for auto insurance, that makes sense. Yeah, I'm going to drive a little more carefully because I got auto insurance, fine. No one of the 27 million Americans who have inhalers are like trying to get extra inhalers to overuse that inhaler. I'm going to sneakily pump some. Like, it's absurd. And it's hurting people. Some people can afford it and it's just an inconvenience, but some people can't afford it. And it's preventing access to the treatments that their doctor says they need and that they need to enjoy the quality of life that they deserve. And so it angers me and it perverts the purpose, the glorious purpose of health insurance.
And I don't think too many cancer patients intentionally got cancer and now
No.
are asking for
No, there's no moral hazard for diabetes or cancer or asthma.
So one of the areas that I want to talk about is price transparency. And, I get pushback because people say, is price transparency really the panacea that you think it is? And I say, no, price transparency to me is not the panacea, but I think we need better data in the healthcare system to make better policy decisions. And this starts with transparency. And I had discussions, besides you, I've talked to CBO staff and everybody else, and they've admit they don't even have the full data picture.
Yes.
Because it's only one entity that really captures all of this. So what do you think about transparency to start with? I'm not saying it's the end point.
So from a policy perspective, I agree. And just to give you a sense of how opaque the system is, the Federal Trade Commission has an antitrust investigation against the big three PBMs. And there's no kind of lawyer like a health insurance company lawyer.
Right.
And they asked, the FTC asked these health insurance companies, hey, we need to see your table of organization from a company perspective. We've got to see who does what so we know who to ask for certain information. One of these three health insurance companies sent the FTC back a phone book of the company. That's the kind of arrogance that we're dealing with, where they just haven't had to answer questions for so long that they don't even know what it feels like anymore to have some scrutiny. And frankly, that's a little bit on us.
Yeah.
For 25 years, the federal government allowed consolidation and vertical integration, so that now United Health Group is Fortune 5 and CVS Caremark is Fortune 20. They're too big. They're not transparent. And it's not just, by the way, the pharmacists who don't know what's going on. It's not just Medicaid, not even just CMS. I talked to a very well-regarded insurance company who runs a lot of coverage for a big state, whose own pharmaceutical management team has no idea what their own PBMs are doing to them. Right. So I totally grant you that transparency is a big issue. It's why I believe in NADAC reporting. and NADAC reporting is basically this imperative that companies, that pharmacists, including the big retail chain pharmacists, need to report the actual cost of goods sold. They need to report what are they actually paying for the goods that they're receiving, because otherwise there creates the shadow market of all insurance companies billing each other made up prices. But politically, we can't just get transparency, because
I agree.
in Congress, you get one bite at the apple on an issue every few years. And if we just get transparency, it'll be a missed opportunity.
Fully agree. And I think you made a good comment that we don't know what we're paying for. Even the consumer doesn't know a lot of time what they're paying for. You know, they show up at the pharmacy and sometimes it's $25 and sometimes 10, and sometimes they're using an insurance card and they overpay for the
There are
medicine.
times, not infrequently, for generic drugs where the patient at the pharmacy pays more out of pocket for that generic drug than the insurance company does. That is a broken insurance system.
I want to get to that point because, you know, the brand market is corrupted, but most people take generics. I mean, generics make up 90% of prescriptions dispensed in a pharmacy are generics. And if a generic is available, about 95% of the time, it's a generic that gets. But they've sort of bastardized that market as well with spread pricing issues.
Yeah.
So can you talk about a little bit about what the generics and why is that important to get that fixed?
I think first, real quickly, just the difference between a brand and a generic. Brand drug is a new drug that a pharmaceutical company has invented, and they're the only ones who provide it for a set number of years, and it depends on what kind of drug it is. Generic is after that monopoly has expired, other competitors can come in. And this concept of genericization of drugs has been one of the greatest bounties to all mankind ever. It has created a massive amount of almost free medical innovation available at your fingertips. And there's different kinds of abuses in the two different kinds of drugs, but the kinds of abuses that the pharmacies, the PBMs have done with generics is twofold. One, generics were too cheap. There wasn't enough margin for them. And so they started calling them specialty drugs. And there is no definition of a specialty drug. Let me be very clear about that. It doesn't exist. It's just what a PBM formulary manager says it is. But suddenly it's got that specialty designation. And oh boy, now we got to charge a lot more to the pharmacist and to the patient. And now it's all very fancy and this and that. So one is just blatant abuse of classification. Two is what you said with spread pricing, which is where, particularly in Medicaid, the PBMs are billing Medicaid much more than they are giving to the pharmacist. One independent pharmacist goes bankrupt every day in this country. And that's because the big three are driving them out of business with things like spread pricing. And then to add insult to injury, this pharmacist, small business owner, a frontline medical provider, trusted in their community, cares about the work that they're doing. I've met dozens of them now. Now, they're going out of business because of spread pricing and other abuses. And then the big three comes and they make them an offer to buy. And it's a low ball offer, you better believe it. And that's how they are aggrandizing the monopoly that they have built.
Yeah, and it's a shame because, I mean, if you look at the data, 90% of Americans live within 5-mile radius of a pharmacy. They're much more accessible in low-income communities, underserved communities. So it's a shame that pharmacists are going out of business, especially the community pharmacists.
They're an underutilized asset in American healthcare delivery.
So overall, we talked a lot about this stuff, and I don't want to regurgitate, and we can take questions from the audience, but this is a bipartisan issue. As bipartisan as you can get. I've been in offices of both Republicans and Democrats, and they complain about the same issues. And most of it's personal. Actually, it's happened to them as consumers in the pharmacy. So can you tell me what you're doing across the aisle? Who are you working with? What are you guys planning on doing?
I am working on a series of legislation. Some of it's been released, some of it hasn't. Most of it's bipartisan, not all of it. And as you said, this is an issue that passes committees by votes of 12-2, 14-1, sometimes unanimously. That doesn't happen very often on complicated healthcare policy. It is also being ferociously lobbied against. The Pharmaceutical Care Management Association, PCMA, that's the PBM's lobbyists, they increased their lobbying by 2x last quarter. I think $3.5 million to $7 million just on Washington lobbyists last quarter. And I'll be blunt, it probably paid off for them because we had this four corners, meaning Senate, House, Republican, Democrat agreement on PBM reform, and it fell apart at the last minute. And, I don't get invited to those rooms as they get very small and very high level, but I got to imagine that PCMA rather got some of their input in there. So we've got to fight back.
Yeah.
And it's got to be bipartisan and it's got to be aggressive because they're going to be aggressive.
And it's personal. It's personal for a lot of us.
It's personal, but we need to do a better job of making it personal, both to lawmakers and to constituents, because it sounds like some abstract fight between pharma and health insurance companies. And it's like, oof,
Yeah.
And instead it's got to be about a vision for a future in which pharmaceutical companies are evaluated on how good their scientists are and not on how good their formulary management team is and how good their lawyers are. And health insurance companies are evaluated on whether they keep their promise to patients, that they're going to be there when they get sick. And pharmacists are evaluated on the quality of the care they provide. We want people to be
Amen.
doing their job. And unfortunately, so much of this gamesmanship has gotten in the way.
Amen. I agree. So prediction for legislative action?
I think the next opportunity is December. It'll be a lame duck session of Congress, and there are some expiring healthcare policies that will force some kind of a healthcare bill. So that train is leaving the station. Washington, D.C. is, in Washington, it's not very hard to write policy. And it's not even very hard to figure out how to build a coalition around that policy. That's work, it takes time, but it's not rocket science. What's really hard is figuring out the when. It's what train is gonna leave the station and how do I get my luggage on that train? And the next train is December, it looks like. We're trying to get our luggage on that train. We'll see, but next Congress, there could be an opportunity as well.
So before we take questions, what other healthcare matters are you working on or you have an interest in besides PBM reform?
Oh my goodness, so many. I'll just stick with one. Massachusetts is well known for R&D, obviously. The next opportunity for us is not just to double down on R&D, but to also become the epicenter of biomanufacturing. We need a CHIPS 2.0. So CHIPS 1.0 was semiconductor manufacturing. Spent a lot of money on Intel and TSMC to try to do semiconductor manufacturing here in America. I think reasonable people can debate how effective that money is going to be. Biomanufacturing can be a huge winner. It's going to create a lot of jobs, and Massachusetts is poised to dominate.
It's one of the manufacturing things that we do well in the United States.
Hugely so. And if once lost, manufacturing tends not to come back.
That's so without further ado, I want to take any questions that the audience may have. You, sir?
That's a threat to the 340B pricing program. Because I've been just kind of hearing that with pharmacies from community health centers, just saying they're getting a lot of pressure on the discounts for the 340B program.
I mean, I'm biased because I'm going to make a pitch about Pioneer because Bill and I have this website up. It's 340B abuse. And what you will see is that if you go to that, and by the way, the data is all from HRSA and from RAND Corporation. Yeah. So this is not some made up Pioneer data. We just arranged it. And one thing I will say is that if you go to the place where we have all the contracts, so we have contracts with all the pharmacies in the United States, and the top 12 pharmacies that have the most contracts, the 340B contracts, number 1 is Walmart, number 2 is Walmart. The next 10 are PBM-owned pharmacies. This is a program for the needy that's supposed to serve the needy, right? So it's being, again, taken over by the PBM-owned pharmacies and PBMs, and that's why the Congressman is trying to shed more light into this issue.
Yeah. 340B is clearly not being used as it was intended. It was intended to be a way to help underserved hospitals provide affordable medications to their patient populations. And it has since become a way to pad margins for a lot of hospitals in conjunction with the PBMs. This is one of this issue and like immigration are the two hardest issues in Washington, D.C. I am not making any commitments that we're going to tackle 340B reform anytime soon. Let's take on the PBMs first. 340B is very tough because the hospitals are very intent.
If you think lobbying is hard by PCM, right? Yeah. Hospitals are like astronomically more. Yes, sir.
what are what are the 2 or 3 major reforms
Yeah.
you'd like to see with PBM? Get rid of the rebate?
Yeah,
The
the most.
I have clients that are paying 90% rebates to these guys.
Yeah. So I'll put in out a couple. The first already happened, which I'm very excited about, which was the Consolidated Appropriations Act fiduciary standard for employers. So what that means in plain English was it said to employers, you are now responsible as a fiduciary to what kind of healthcare benefits your employees are being exposed to. So it's trying to get our healthcare ERISA plans to a place where retirement benefits are. Our retirement benefit system actually works pretty well regulated, it's very competitive. And if you're an employee and you're saving up for your 401k, you actually have a lot of confidence that what you are buying is pretty low fee and well managed. That does not exist for health plans. It's just like a complete Wild West for health plans. And what this rule said was, hey, employers, you got to do a better job. You got to ask some better, tougher questions of your health plans and your PBMs. That's beginning creakingly to happen. We're going to see some litigation, and we are going to see PBMs be forced to turn over their ledgers and stop doing this kind of kabuki theater of hand waving for employees. That's number one. Number two is my legislation is going to drive delinking. Delinking is, to me, the keystone policy. And what that is it says to PBMs, you cannot get paid on the list price of these medications. You have to be a flat rate provider of a service, because the PBMs fundamentally provide a technocratic service. It's software at the end of the day. It's really not that complicated. What formulary tier you're in, is it a brand or a generic? If it's a brand and there's a generic available, did you ask the physician first if they really need, there's like a couple forks in the road, just not too complicated. Charge a flat rate for it. No more getting paid the higher the list price goes. We do that, we start to change the industry. That's what's ruined the system. And the rebates get wider. List prices are going up, net prices are going down, but here's the thing. What you pay at the pharmacy counter and out-of-pocket costs is not predicated on that net price. It's predicated on the list price. So the higher that list price goes because of this, I call it a negotiation, but it's weird to have a negotiation where the price goes up. But the higher that price goes, the more you're paying out of pocket. And for people with cancer, for people with chronic disease, that drives people into medical debt.
Yeah.
So that's it. It's fiduciary and it's delinking.
Why don't we go to the gentleman in the back? He had his hands first.
Thank you, Congressman. You said that the lobbyists for the PBMs are doubling down, and they must have some arguments that
Yes.
you haven't presented that are pretty good.
Yep.
And if they don't, then is Congress just too stupid, or too is it lack of courage? Are they worried about the money they won't get? Is it that much from this industry? Why
I love that question.
why are they convincing?
I love that question because it's exactly the question I ask my staff on every bill they put forward to me is what's the strongest counter argument against? Because if you can't articulate it, then you don't actually know your own argument. I love the question. It's a great one. The strongest argument that you would hear from the PBMs would be twofold. One is they would come up here and they would say, nobody's negotiating with the pharmaceutical manufacturers. We're the ones doing it. If you want pharma to come and just run roughshod and charge whatever they want for these drugs, for Ozempic, right? The GLP-1 inhibitors. Everybody wants Ozempic. Everyone's trying to get Ozempic. You want Eli Lilly to charge, $50,000 a pop, then take us out of the equation and they'll run roughshod. And they are right that somebody needs to say no to pharma. We need formulary management. The problem is that that should make the prices go down, not up. So strike one against them. The second argument that they would make, and they're increasingly making it, is, hey, listen, we're just the technical experts. The plan sponsors, aka the employers or the unions or Medicare for that matter, make the decisions about how to balance between out-of-pocket costs and premiums. That's up to them. And there is a little bit of validity to that. No one's hands are totally clean in this. It is true that plan sponsors, a lot of employers probably are subsidizing their healthy employees with their sick employees. That's valid. The problem is the system is so opaque is that nobody knows that, which is why this fiduciary standard is so important, is it just put the facts on the table. If you found out that your broker for your retirement accounts was getting paid to offer you certain kinds of advice, you would be asking some pretty tough questions about that. And that's what we have in healthcare right now.
You're absolutely right. I mean, a lot of employers don't do a good job. I mean, when we complain about patients showing up at the pharmacy and paying the list price, they may have a choice to actually lower that,
Yeah.
but they don't want, they
it's
either
true.
don't want to, or they don't know to ask the right questions
That's right.
also. Yes, sir. It is a specialty pharmacy.
It's a special.
Yes, yes.
So I think they passed the legislation under one of these acts that happened during this administration where they're going to cap the price I can pay in Medicare
Yeah.
at $2,000 or something,
Yes.
which
Mhm.
I paid almost nothing when I actually worked. But now that I've retired and I'm on Medicare, it's spiked way, way up.
Yep.
So this will bring that down. Is there more of that they can do, or is this a one-off thing that you think they're not going to let that happen again?
So the question is about out-of-pocket caps. And so what Democrats did last Congress, and I say Democrats because Republicans didn't join us on this one, it was paired with the climate change legislation we did in August of 22. We invested in climate action, and then we empowered Medicare to negotiate drug prices. But actually, the most impactful thing for patients was not the empowering Medicare to negotiate drug prices. It was the out-of-pocket cap.
Mhm.
So starting this year, it was $3,500
That's-
cap. Next year, it'll be $2,000. And $35 for insulin per prescription. Robert, you may know more. I don't know that the PBMs actually quite know what they think about that yet. They are trying to figure out how they're going to game the Part D formulary now because there's no requirement that the negotiated drugs actually have to make it onto the
That's
best
right.
tiers.
That's right.
So if I had to bet, I would say the PBMs, and they're very good at this, are sitting there looking at new regulations and saying, how do we game this now to our advantage? I mean, this is United Healthcare's prime differentiator is doing that. They're going to be, that policy alone is not putting them out of business. They're going to be just fine.
Well, I can tell you on the private sector, what they're doing now, because, not because of the Inflation Reduction Act, but more because of the genericizing of the market. They're going to employers and telling them, you know what, we guaranteed you what X amount on rebates. Well, guess what? You're gonna have to claw back some of that because we
Yeah.
can't meet the rebate dollars. So they're going back to employers and taking money off of them, which is, they don't know what to do. I agree with you.
Yeah,
I
they're still
think
making it
more
up.
to come on this one. I think how the behavior is going to change. Come over here.
First of all, thank you very much for coming.
My pleasure.
One of my biggest fears living in the Commonwealth, if I was to say to my children, oh, come back to Massachusetts, is right now we have a governor who is telling us that we're going to be paying over $1 billion a year out of our budget. Of course, we're a rich state. She must think we can afford it to accommodate thousands and thousands of people who have come to the Commonwealth who are not supposed to even be in the United States. They didn't come legally. I'll say it, they're not here legally. And we are picking up the tab here in Massachusetts. So if I was the owner of a biotech type company and I'm in a state and I'm saying, you come to me and you say, hey, we're going to do great things for you in Massachusetts. We have the universities, we have this, we have that. And I did my due diligence. I'd say, hey, your state is very poorly managed. You've got all kinds of money going everywhere and it's not going to business. You just raised the millionaire tax. So I've got a bunch of shareholders who are involved in the company, want to create new exciting products, want to make money. And your state is not money friendly to businesses. And your governor is more interested in helping everybody in the world except the people who live in this state.
Well, I think our
That's what
governor
I
is,
want.
trying to manage a very challenging situation that frankly is not of her making. It is of Congress's making. And hold on. So Congress needs to pass comprehensive immigration reform. I'm a co-sponsor of multiple pieces of bipartisan legislation to do that. It has to include border security, has to include documentation and dignity for dreamers. And it also, and I think this is particularly salient for Massachusetts, needs to recognize that we're a nation of immigrants and Massachusetts has been welcoming people for 400 years to come and build lives here. And these biotech companies, yes, they want a pro-growth tax regime. They also want talent. And immigrants have been the primary mavens of biomedical innovation for the last 30 years. You can think of 3 companies that just launched game-changing cures: sickle cell disease, ovarian cancer, heart disease, founded, led by physician scientists who were born overseas. So Massachusetts benefits from immigration. We need more of it. Got to be done through a legal and orderly process.
I agree. Fully agree. Yes, sir.
Worked in the bowels of healthcare data for 25 years, and there's not better data. So, one of the things I wanted to get your kind of thoughts around are this combination of kind of failure and innovation, your opening comment around innovation. Why do we choose in healthcare that failure is bad? It feels like, we're a capitalist country and you got to run by the market drivers, but then there's always this kind of finger on the scale in healthcare, and we decide you got this shenanigan tax code that props up nonprofits versus where are we going to start allowing for failure that kind of is the foundation for new innovation? I don't see a balance if you want new innovation when you're carrying a backpack of just old status quo thinking and ingrained interests. It feels like we're spending so much more time and money expecting these institutions that are benefiting off of the broken system to change versus creating ways by which to incentivize people that would put them out of a job tomorrow if we really had equal market forces and opportunity for all.
Yeah, I mean, I think the 2 sectors of healthcare that are disruptive in the pure sense of the word, replacing services with goods, really, which is the way to take cost out of the healthcare system, is med tech and biotech. Those are the 2 things that keep people out of either inpatient or outpatient treatment. And so when you think about in healthcare, supply creates its own demand, right? The more services, the more treatments we have out there, the more people are going to want healthcare.
right.
Quite rightfully so. I think it's actually a very civilized thing to do. As a society gets richer, it says, well, let's spend money on education and keeping people healthy for longer. That makes a lot of sense. Very expensive. And by 2050, we're going to have 17 million Americans with Alzheimer's, each of them requiring 3 round-the-clock caregivers. We don't have enough people. We don't have enough money for that scenario. And the only thing that's truly disruptive would be a cure.
That's right.
And so that's why we have to promote biotech and medtech innovation. Those are things that replace services with goods.
And I don't have a problem with failure and healthcare failure. I mean, part of research is to fail before you succeed. And people who think that research happens very simply, it doesn't. It's very complicated. I mean, I always reflect back to in 2017, I was sitting at Pfizer and they were telling me about gene therapy Pfizer was going to come out with. And they were going to come out by 2020 about 2 gene therapy drugs. We're at 2024, they don't have anything. It's complicated. These things are very complicated.
The
And
COVID
failure is-
vaccine wasn't supposed to work.
No. And it's-
mRNA was a
and it wa-
panned idea.
for 10 years, people worked on mRNA, they couldn't figure it out. So failure is part of research and part of healthcare. It's just that we need to embrace it and understand it. But I agree with the Congressman. Everything he said. It's best thing that we have.
Okay.
Final question. Okay.
Okay, this is related, but I'm sure you've seen that the interest expense on the federal debt is expected to exceed defense spending next year. So one of the drivers of the deficit is healthcare spending. Like to hear your thoughts on entitlement reform.
On what was the last?
Entitlement reform.
Entitlement reform, yeah. 5 big things. $34 trillion of debt, adding $1 trillion a year, not sustainable. And Paul Krugman writes about this in the New York Times. Some of you may read him. And every once a month, Paul Krugman will write a piece saying, don't worry about the national debt. It's fine. It's a bunch of scolds. And he's wrong. I like Paul Krugman. I read him. My constituents read him. On this issue, I just don't agree with him. We cannot be in a situation where if we had to fight a war right now, we'd have to borrow every single dollar necessary to fight that war, because our actual earned budget that we actually have revenue for goes towards entitlements. So you're totally right. The 5 big drivers are Medicare, Social Security, interest on the national debt, which is growing fast, the military, and then everything else. Everything else is about 17%. So everything that we fight about in Congress all year long, let you in on a secret, None of it affects the national budget whatsoever. And this is my problem with my friends across the aisle who cast themselves as hawks on the budget, is they'll come up with an argument, we're going to cut heating assistance for low-income families, and we're going to cut 200,000 Head Start slots, and that's how we're going to balance the budget. And it's like, no, you're not. That's just, it's decimal points. You can pick up the Pentagon and shake it, and that much change comes out of the couch. Any serious conversation really has to be about Medicare. The military is actually not even really driving the national debt. Social Security, we know what to do. It's a little bit of higher taxes. We can get bipartisan support for that. It's all about Medicare, because the costs associated with Medicare, even though the trajectory has actually improved over the last decade, are exploding. And one of the reasons they're exploding is actually because of some of the successes of healthcare. People have much
Living
longer
longer.
lifespans, but their health spans are not necessarily keeping up, particularly with neurodegenerative diseases. Alzheimer's is the big one. That's right. The best thing that we could do for our federal debt has nothing to do with entitlement reform. It has everything to do with curing Alzheimer's.
Exactly, because the indirect cost in Alzheimer's is significant.
Massive.
That was the last question, right?
I appreciate everyone joining us.
Thank you.
Thank you.
Thank you, Congressman.
Would like to thank the Congressman, Dr. Popovian. Drink for your birthday, you have to. But I'd like to have us close with Colby Hewitt, who'll be providing some final remarks. Thank you very much, Colby.
Good evening, everyone. Please join me in thanking once again Congressman Auchincloss and Dr. Robert Popovian for this evening's insightful conversation. Thank you all. I think we can all agree they've identified some critically important policy issues that need to be addressed. Chiefly among them is how legislators can keep hard-earned dollars in the pockets of patients dependent on life-saving medication and not in those of PBMs. Thank you both for your continued efforts in raising awareness and driving change. For those of you I've not yet met, my name is Colby Hewitt. I'm the proud grandson of Colby Hewitt Jr., the namesake of the Hewitt Healthcare Lecture. When I think back to the earliest memories that I have of my grandfather, indeed, just about all of my memories of my grandfather are painted in some way with his commitment to the Commonwealth and to Pioneer Institute and the good work that's done by Pioneer Institute. His position as Pioneer's chairman was truly a role that he held dearly, and we're so grateful to have his legacy honored each year in such a meaningful way. As we look to the future, we know Pioneer's Life Sciences Initiative will continue to be a champion for patients' access to breakthrough therapies, and we encourage all of you to join in this important effort. Thank you all for attending, and have a wonderful evening.